Uh, so yes, it's my pleasure to introduce Jessie Tennenbaum, um, whom actually I had never met before.
Yeah.
And and I cold emailed her at some point in summer, I think. And I said, you know, we're running AKBC, and I see you're doing work with real data and knowledge extraction and data-driven policy, informing policy with data. And I was like, that's fantastic. That's what we want. And she's telling me, but are you sure? I'm looking at your conferences, and like, you know, you are all into these fancy models and stuff. Like, you know, but really, like, you know, you don't. My work doesn't have anything to do with these fancy models. Really, it's mostly about getting the data right, or at least that's my interpretation of what or how our discussion went. And then. Yes, and then I said, no, that's exactly what we want. In fact, I was talking to someone in my group in Cambridge, and he said, yeah, no, that's the talk we need. So, well, you know, without further ado, that's the talk we need by Jessie Tennenbaum on data-driven policy for pandemic response. Data, knowledge, and action well outside of the ivory tower.
Thank you so much. So thank you for inviting me, despite my confusion at first, to be here today. So I'm affiliated with Duke University. I'm faculty there, but I like to say I'm in my 4th year of a 2-year stint with the state of North Carolina's Department of Health and Human Services. So first I want to give a disclaimer. This is my dolly capture. I was trying to decide if I was going to go with the elephant in the room or the ugly duckling, one way or the other. The fact that, like, I'm not building nor even using knowledge graphs. Why am I speaking at this thing? And Andreas captured it well, where he said, we want that other perspective of kind of like, how is this, in the biomedical space, we talk about translational medicine. Like, how is this really being used in the real world? So I'm here to give the perspective of this thing that happened recently. It was called COVID, might have heard of it. Talk a little bit about how we looked at data in that context. So North Carolina's Department of Health and Human Services. First, actually, I was going to do kind of a little poll of like how many here are from the UK versus America versus other places, but I won't be able to see the online, and so we have a missingness not at random issue, so I'm not even going to bother with that poll. So North Carolina is one of the 50 states. We have the Department of Health and Human Services. It covers everything from Medicaid to public health to mental health to child protective services to testing well water for chemicals to testing restaurants that they're adhering to kind of cleanliness rules, veterans and vital records, births and deaths, and kind of many other things. So that's sort of the scope of what we do. In 2019, the then leadership said, you know, we provide all these services, and that's great and important, and we've been doing it for decades, but we think data is pretty important. And so we want to really start thinking of data as not just a geeky IT side gig, but a strategic business asset. And so they created the data office, created the position of chief data officer, that's me. And my mandate was to do nothing short of driving departmental cultural change in the way we think about and use data. So we developed a strategic framework involving 5 pillars: infrastructure, governance, quality, use, and data literacy. I'm going to talk a little bit more about the details of those. So the data infrastructure, kind of basic, that's where we partner closely with our IT division. Importantly, the data office is not part of information technologies, not part of IT. And that was strategic to say, like, this is a business strategy aspect of what we do. This is not just that side geeky thing. Data governance, meaning how do people even ask for the data? How do people get hold of the data they need to do their job? How do external people ask for it? What are the processes by which they have to make the request, and who decides based on what criteria? Profoundly unsexy things, but take up a lot of my time and are very important. Data quality, which is often considered part of governance, but it had been so neglected for a while that we wanted to call it out explicitly. Data literacy, and here we're talking about kind of informing the whole staff personnel work base. I heard a useful description at a conference I went to where they talked about raising the ceiling and raising the floor. So for the ceiling is not the audience here today. It's not people using knowledge graphs. It's like the ceiling tends to be people who are masters with pivot tables in Excel. So getting them to kind of understand coding and best practices and that sort of thing. And then the people that get like breakout in hives when you mention data or ontology, just getting them a little more comfortable with some of the concepts that we discuss. So I think when they created, oh, sorry, I didn't even do, so that was data literacy. Data use, I think when they created the data office, they were thinking that was what it was going to be, like this interesting analyses and modeling and prediction and machine learning and all that. But when I came in and sort of started exploring and finding out, oh, you're faxing those things to each other. Oh, the way you exchange data is that you email a PDF. We had a lot of work to do before we could have the luxury of asking and answering these interesting questions. So this is lovingly referred to as our staircase slide, put together by my colleague, Haley Young. Basically what I'm saying is that we had to put our house in order, this foundational lower levels of this, of kind of just data collection, data cleaning, integration and reports, these basics, before we could get up higher and do some of the more interesting work. So up until now, we've really been focused on sort of the first 2/3 or so of this staircase. I just realized I wanted to time myself to make sure I'm not standing too much in between you guys and lunch, but we'll see how it goes. Okay, so apologies for this, because I realized that, so what academics are focused on. I think I've seen a few slides that have made me giggle a little bit, like this is gonna resonate. You know, and these are great, this is important and can do very cool things. What the most of the world really needs is some SQL statements with group by and summarize and maybe count. Mind you, it has to get into a SQL database first. It can't be stored in PDFs. And then in our context, in public health, some geospatial data on top of that is extremely useful. So my background training is in biomedical informatics, and we talk sometimes about the central dogma of informatics. So as opposed to central dogma of biology, you may know as the whole DNA to RNA to protein. In informatics, we talk about data to information to knowledge. So you start with the data, that's just the ones and the zeros and the numbers. Give it a little bit of context, becomes the information. Figure out kind of the insights. What do we mean by that? What do we want to do about that is the knowledge. And then some other models, I like the one of action. Basically, I don't want to bother with data unless there's something that I'm going to do differently because I know the answer to the question that I was able to get using that data. Some of the other takes on this are wisdom, etc. You've probably seen this cartoon that's everywhere. We can go from data to information to knowledge, to insight and wisdom, connecting the dots, and then there's conspiracy theater. I don't know if you can see QAnon is down there. In Googling for this picture, I actually found this one that I really like, data to information to knowledge to action. What are we going to do about it? What are we going to do differently based on having this information? So when I first joined DHHS, there was this one example brought up over and over again that had been part of this New England Journal paper, where they said, we have lots of people, and so now it would be useful to know who's familiar with the concept of Medicaid in America. Only a few. Okay, so Medicaid is basically what you guys have for everyone here, is the universal coverage of healthcare for people who meet certain criteria, typically mostly about your low income level, and then some other things. So we have many, many women who get their healthcare covered by Medicaid, and they are having, they may be pregnant, having babies, and that means they are also very likely eligible for this program called WIC, Women, Infant, and Children, and that does nutritional support and gives additional food and formula and that sort of thing for women and children. And so the question was raised of how many women do we have in Medicaid, pregnant, who are probably also eligible for WIC, but not enrolled in WIC, who ideally would get enrolled in WIC, and then we could give them the services and it would be better outcomes for them and their children. So pretty simple question, or at least it should be, but these two data sets lived in completely different places. They were governed by different laws, and it took months to just get that answer. I'm not going to go off on a tangent because I don't have time. In order to get that answer, we needed to do two things. One was to merge these silos of data we have. Another is that you need to be able to identify that, say, Jessie in this data set is the same as Jessica in that data set. In the case of the WIC data, it was actually relatively easy because they did use the same identifier, but I'll talk a little bit more about that. We interrupt our regular scheduled data office stuff to talk about COVID. So I had been in the job 9 months, and then suddenly not suddenly actually, we kind of were watching for it like, okay, it's coming. March 10th, 2020, state of emergency in North Carolina was declared. When that happens, when there's a state of emergency, the operation headquarters becomes this building down there on the left, the Emergency Operations Center. Usually this is activated for like hurricanes and that sort of thing, where they'll have these news updates and give people the information they need. There is actually a room called the Situation Room, and that's the inside of the Situation Room. This was before we were masking, but everyone was social distancing, and you can't see, but there were like hand sanitizers every 5 feet. So suddenly this happened, and we were called into the EOC to say like, okay, what are we doing? And so we had a lot of questions that we needed data to be able to act upon. So things like, how many cases are we gonna see? When will our epi curve peak? When are we gonna see the highest amount of cases? How much extra PPE do we need, and where can we get it? This was a key one. Are we going to run out of hospital beds or ICU beds or ventilators? And then in hindsight, it seems like, yeah, that was a question we had, but should we shut down bars and restaurants or schools and businesses? At the time, that was like, whoa, that's pretty severe. And then, we moved into that space where clearly that needed to be done. You can argue how long it needed to be done for and whether it was the right one with 2020 hindsight. And then also, how can we support families who are unable to work either because their workplace was shut down and so now they don't have an income, or they're first responders and they need to work, but they don't have childcare for kids. So you can think of these very heterogeneous buckets of different data types that we had. There was initially testing in cases and what we call med-surg, so the different hospital supply they had. Later, we started doing wastewater. I forgot, it looks orange there, but it was kind of brown, haha. Later, I remember distinctly the day they said, okay, we're gonna start up a new work stream, vaccines. And it was like we were turning the corner, like, oh my God, there's the end is, not the end, but next stage is in sight. Contact tracing, figuring out monoclonal antibody treatment, and PPE. So I don't expect you to be able to see any of this diagram really, but what I wanna convey here is, at the very earliest, before vaccines and the wastewater and all that, we had cases, we had testing, and we had capacity, as it was explained to me, staff, space. So for the testing data, for example, the way that had been previously collected, typically for for communicable diseases, is they would fax it, and someone would get the fax, and they would hand enter it into a system. And it was only the positive ones. But now we wanted to know not just the tests that were done that were positive, we also wanted to know the negatives, because we needed to have a sense of kind of percent positive and where this was going. And so the way it was done initially, the guy who was in charge of emergency operations, who normally hands out sandbags in hurricanes, was calling up LabCorp, the major tester in the state, and saying, hey, how many tests did you do for COVID in North Carolina yesterday? And how many of them were positive? And he'd write that down and then hand it to someone next to that situation room, actually in that situation room, and then they'd take it and put it in a PDF and email it to that group who would look at it and then convert it to this, and it was a mess. So that's where we started. I'm pleased to report that after a few months, we had a much more elegant, automated, cloud-based system where now, again, complicated screen slide, don't need to understand all of it, but now we have in the bottom all these different data types. We have ETL pipelines that put them into our business intelligence data platform, the sort of central data warehouse, and then we use that to do automated population and refresh of our Tableau database, or of Tableau dashboards that are available to the public. So that seems pretty straightforward, but I wanted to give an example of why it's not as straightforward as you might think. So there was this concept of, are we gonna run out of beds? And you think, okay, well, you have a bunch of beds, and a subset of those are ICU beds. Cool, so far so good. And then some of those are occupied and some are not, and we wanna make sure that we're not gonna exceed the number of beds with the ones we need occupied. But that's not the end of the story. You also have physically available beds. So you may have way more beds, but if you don't have the need for them, they're not staffed. So are you talking about the ones that we have staffed, or are you talking about physically available beds? You also may be licensed, and I'm not sure how it works here in terms of licensing, but you may be licensed to have 400 beds, but you only actually physically have 300 or 350. Do we count those or not when we're counting capacity? There's also a bunch of beds that are for outpatient and observation. They're not meant to be used for overnight stays, but in a pinch we could do that. And then there's this concept of surge, and unfortunately, different groups define surge beds differently. So some it was about the physically available beds that were being used that had never been staffed before. For some it was, okay, we were licensed for this many, so we're gonna build out some of those ones we never had before. Some it was those outpatient and observation, and then some it was, we've got a tennis court next door that if we needed to, we could stick a bunch of beds and accommodate patients there. So what seems fairly straightforward of just how many beds do you have and how many do you not so straightforward. So you probably saw some version of this. This was the whole, we need to flatten the curve. And this was sort of encouraging people to socially distance and wash hands and all of that so that we wouldn't exceed our capacity. So this is the part where we're doing some modeling and machine learning and stuff. Don't blink because you'll miss it. We compared it to hurricanes. So with hurricanes, you develop a model, you sort of develop a bunch of models, you average them out, you get a nice kind of curve like this. What that actually is a bunch of different models, and you're kind of averaging them to show the path. This was one of my proudest moments. I was turned into a comic superhero to explain how it is we do these and how the models are kind of like hurricanes. And people were saying, but what if the model's wrong? And so this was me explaining, it's not that the model was wrong. If we're out at one of these outer edges, it just went to the edge of the curve of what we expected it to be. And we worked with some local researchers doing some advanced modeling. One was an agent-based model. And so what they did was they sort of simulated people, these like mannequin people, and they modeled their physical location, health status, and life status every day, and the R naught, or what was it, R naught and RE rate as time went by, to say like this is how likely it is for people to get infected. This, and so next slide is what they refer to as a SEER model: susceptible, exposed, infected, and recovered. So looking at like we're seeing the cases. But there's a whole bunch of them that we're not seeing, and there's a whole bunch of potential exposures that could turn into cases, and understanding how that's likely to trend over time. So that was a useful collaboration, and they would give us these weekly models that looked something like this, but for all the different regions, in addition to statewide. And so that blue line is that curve that we're trying to flatten. The red line was the capacity of our ICU beds and non-ICU beds. But the thing I want to point out is you can see in the top right, this model was showing that we were going to exceed capacity. So that's scary, right? Like, we're going to run out of beds. But fundamentally, when it came down to it, we were like, nah, it doesn't really feel right. Like, based on the people on the ground, the people who kind of do this every day and look at the capacity and talk to each other, they were like, yeah, I'm not too worried. And so we had this model. It was telling us something, but in the end, in terms of actionability, it didn't require action because we said that just doesn't feel like where we're heading, and we're not worried. So that was my note that. I will mention that where AI has proven useful is in process automation. So basically all these drudgery tasks that I mentioned of like if you're taking an Excel spreadsheet and you have to upload it to here and paste this here, robots are great at doing that. So AI is being used to do that, and that's actually saving people time. Usually, it's not a solution in itself, it's just a Band-Aid for a poorly designed system, so ideally we're gonna upgrade, and we have a whole data modernization initiative that will hopefully improve those, but in the meantime, we've got some robots helping us out. Okay, so switching gears slightly, but referring back to Partha's talk about inclusivity, we know that COVID disproportionately impacted historically marginalized populations to a significant extent. So this is showing the 50 states in the US, the relative deaths and cases of, I think in this case it was African American, compared to white. And so it's problematic, much more impacted in the orange, and then you can see there's a bunch of gray ones where we just don't have enough data, is what it indicates. So you can't improve what you can't measure. If we're not collecting the data, then we can't do anything about it, we're just sort of flying blind. So we wanted to understand the number of COVID cases and deaths and how the race and ethnicity were distributed among those, but also the testing. If we find that we're getting roughly the same rates in black and white for cases, are we testing everyone we need to be testing, or are we, again, missing not at random? And then for vaccination as well, understanding what the distribution is for race and ethnicity among who's getting vaccinated. Can I have a time check? What's the time?
We're going to start lunch break at 1:30. You have time.
Okay. All right, stop me if that's not the case.
Yeah.
Okay, okay. So North Carolina, our state, led the country in terms of collecting the data. Especially for vaccine data, we had built, our existing vaccine data system was a legacy system, and it did not meet the needs of what we had for COVID for various reasons. So we sort of built from the ground up in some ways a new vaccine data collection system for COVID, which meant that we didn't have to deal with old habits. Basically, everyone was being trained on this new system, and we were able to say, you cannot move to the next screen unless you collect race and ethnicity data. So we're able to force that. Now, it got more complicated when we were importing data from electronic health records because we didn't want to reject all the cases where that data was missing, but nor did we want them to make up data and have it be bad. So what we would do is allow them to say unknown, but monitor that and say like, hey, we noticed that you're exceeding 3% or 6% or whatever it was. You need to do better. And we had some carrots and sticks associated that we were able to dangle to say like, you got to do better or you're going to have to go back to manual. So what this enabled us to do, does this actually have a pointer? Yeah, sort of. Okay, so what that enabled us to see over time as we changed the relative distribution of who was getting vaccines, and I'm forgetting the color coding, but trust me, we could track that over time. This graph I was particularly proud of. Each of these dots represents a zip code. And along the x-axis is the size, the absolute number of a given historically marginalized population. So in this case, I think it's selected African American. So in each of these zip codes, how many people of African American as their race are in that zip code? And then the y-axis represents, at this point in time, again, the temporal thing, what was the vaccination rate for that population. So the solid line was the state average, the dotted line was the average for that race. And so this was actionable in that we could say, okay, the ones down here are the ones we need to focus on to do community vaccine events so that we're getting more people there. In the interest of time, I'm not going to go into the caveats there, but feel free to ask me at dinner. And then this one at the bottom was overlaying vaccination rate was the size of these are census tract. So this is like a couple neighborhoods together, so pretty refined amount. And this was public data, which in America is really hard to do because people are so sensitive about privacy, et cetera, et cetera. Well, some people are. So this is census tracts, and then the red and the blue show relative social vulnerability index, which reflects a number of things like income and language and transportation abilities and various things. So this, we were able to say, okay, here are some of our more vulnerable. The red shows higher social vulnerability. Here's a red neighborhood where we have a pretty low rate of vaccination. Let's try to make sure that we're targeting that area for these vaccination events or for partnerships with providers in that area. Okay, now that COVID's out of the way, we now return to our regularly scheduled data offers business. So particularly for the Americans, you may remember this pic, maybe others have seen it. This was President Obama in 2015 saying like, we've got this new precision medicine initiative, yay, cool. And a lot of us in the biomedical space, especially in the genomic space, were able to say to our parents like, look, the president's pointing at what I'm doing. Unfortunately, that actually was a little misleading because we've known all along it's not just your DNA. It's DNA and environment and lifestyle. And so likewise in the public health space, it's not just about the healthcare you're getting, it's all the other things. It's your childhood experiences, it's your education, it's your housing, it's your interpersonal violence. All of these have impact on someone's outcome from a health perspective. So North Carolina participated in this national, what's called an 1115 waiver. It's basically like, here, you do something novel and innovative in the Medicaid space to try to make people healthier. Well, to try to either make people healthier or save money, or just give them a better experience, or some combination of those. So what North Carolina decided to do was sort of the precision medicine, well, the all-around precision medicine in the context of the services we offer. So not just saying we're gonna reimburse for healthcare, but also saying if you need reimbursement for a ride to the pharmacy or a ride to the doctor, you get that. If you need reimbursement for a healthy food box of produce to get your diabetes under control, we will use the money for that as well. And so this has been tried in a few models around the country in different places. This was in Chicago, where a hospital, instead of treating directly, was paying some amount for housing, and it's very cold in Chicago. And so you can imagine that'd be very hard to stay healthy if you're sleeping on the street. And they saw a significant drop in ED visits among the individuals given this option. Similarly, in Texas, they partnered with Uber and Lyft to try to get people to the appointments they needed to and found good returns on this. I should say it's still an experiment being done. Like, we're still trying to measure the actual return on investment here, both from a outcomes perspective and a money perspective. But it's definitely innovative new ways. Everyone in North Carolina who is in the Medicaid program gets screened for these different things. Essentially, like, do you have issues with finding food or ensuring food, housing, transportation, and interpersonal safety? And here's the coolest part. This kind of blew my mind when I got to North Carolina. We have this system called NC Care 360. It is now through COVID, it's now in all 100 counties, and it's a closed loop referral platform. So I heard that they were doing social determinants, and I thought that's really cool. You get a referral to, say, a soup kitchen. But this goes further and sort of can say, okay, Jessie's here, she's having food scarcity. Let me look for the organizations in her area that can provide healthy food boxes, whatever it is. And then I put in a referral, and then those community-based organizations can see the referral and say, this person needs help. Okay, I've got it. And then they show, was it resolved? Did they get the box? Did they not have any more supplies? Whatever it is. So we can see the results of those referrals and addressing people's non-medical needs. So what we're aiming for here is whole person health, understanding for the residents of North Carolina, both for an individual in real time to say, you may be eligible for these other things, let's get you hooked up, and from a policy analytics perspective to understand what's working and what's not, and maybe seek to address that. So actually, I think I've gotten at this. These motivating questions basically come down to a bunch of different data systems in our state that are still in those silos that I talked about. So here again, you guys kick our butts in that you have the national health system and people have their ID and you use that ID through most systems, although I bet there's some that don't use it. So back to this, we need to integrate our data silos, and now we don't always have the same identifier. So we need to do this sort of linkage between systems. Here's a bunch of our systems, some with other communicable diseases, some with COVID, vaccines, and cases. And the different colors represent different IDs. And so it's difficult to link them between each other to know that Jessica here is Jessie here and whatever it is. In the interest of time, I think I'm not going to go into the details here, particularly because you guys don't have these problems. And I will just end by saying, oh, I have 10 minutes. Okay.
Well,
I don't want to keep you. I'll do this briefly. So, and especially for the people in the audience that I can't see that don't have a national health identifier. So, we wanted to solve the problem of we have Jessie over here and Jessica over here, and we're not sure if that's the same person because people move and they change phone numbers and they have typos and they have misspellings and whatever it is. So, de facto, what we've been doing until now is that each system uses its own ID. And we do this sort of probabilistic fuzzy match between them. And there's different levels of sophistication with that, and there's different numbers of false positives, false negatives. And that's very labor intensive and prone to error. Another option that I am hoping we can get moving on in the United States that's more similar to the system here would be a national health identifier that you could just use for all of these different systems. And that would make my life much easier. And so where we've landed is somewhere in between, where we have multiple quote unquote standard identifiers, and we map those to each other so that we can do that sort of easy lookup between the systems. So to make this concrete, you might have Angie Taylor here. Her address is 12 Main Street. Actually, her address is not. This is a typo. Her address is probably 21 Main Street. Shows up in multiple places. But here she was Angela. Here she was Angie. Here she just used an initial and used her middle name. And we're able to do this sophisticated probabilistic linkage that accounts for things like misspellings and sound X. So like L-O-R-I may very well be the same as L-A-U-R-I-E. And map all of those. We say, okay, here was the ID in the source system, and we're going to assign this unique ID. And so now we're able to link between and show this is the person, and it's a person-centric view, and here's all the information we know about them. Most of it from DHHS, Health and Human Services, where I am, but some of it with different agencies in North Carolina. For example, schools, understanding how COVID absenteeism impacted school outcomes, understanding how nutrition benefits can impact school outcomes, because if you're hungry, it's really hard to focus and study and learn. That was all I was going to say, and I'm happy to take any questions.
So, questions, yes?
Thank you. That was very fascinating. I was very interested in the data whiz part. So you have this data and you have this knowledge, you do a bunch of steps over there, and then the final part in the situation room example that you sort of mentioned is mostly data whiz. So you visualize the data, and then people prefer visualization. Is that true, or?
Well, it's a combination. It's a combination. So there's data visualization helps them to kind of understand the story there. So the X and Y, I had to get people to understand that. But for like the map saying like, oh, here are the disadvantaged neighborhoods and here's what we need to do. Now, they did tend to convert that and say, okay, please export for me that list of zip codes or the list of census tracts so that I can then go and follow up and decide where to put my things. But so I think it's in combination. There's the data visualization to tell the story and get people to understand it, especially people not necessarily comfortable with data. And then there's the actionability, where you need to say, I mean, if you happen to know where that census tract is, great, but you might have to go and take that and look at coordinates and all that. Does that answer your question?
Yeah, I mean, what I was trying to get at is, would people prefer sort of question answering? So would that be something that people prefer, or would people like visualization kind of thing?
I think it's a little of both. So in the case I just described, I think the question answering would be, which zip codes should I focus on for my community vaccination events? And I think it kind of gets to the machine learning explainability aspect of like, it would be one thing to say, here are the zip codes. But someone might rightfully say, well, why? Like, what are you basing this on? And I think that, especially if you know the area, that can help make them feel more comfortable with how we got to that conclusion. Sure.
Thanks. So my question was about the actionability, and you mentioned, for example, in the model of predicting what you would expect the cases to look like, and then it hits the capacity limit. Mm-hmm. And you said there was some kind of feel that this was not important and not actionable at that moment. Could you elaborate a little more on this interaction between the model and the people on the ground?
Yeah, so the people on the ground, they were, even before COVID, they sort of handled this with the flu in particular. And so there were different regions of our state that have multiple hospitals per region, and they would be in communication with each other and have kind of a gestalt of like, how full are your beds? How crazy is your ED? There was also a time aspect, again, getting to temporal. I didn't realize how much we'd have in common. I don't know if you remember, but it exceeded it pretty far out, which, as we know, you're getting less accurate then. So it was sort of we've seen this before. We know that we can't have all the information for 30 days from now, but based on where we're at and based on what we've experienced before, sort of as human anecdotal, they could have been wrong, right? Like, it could have been that the model was actionable and we should have been panicking. It didn't end up that way. But the modelers, if they had been right, could have been like, we told you so. So it's just, I think it speaks mostly to just the human element of this. Again, but getting back to the whole, like, how do you believe it? You have to make sure that the people taking the action trust the models.
Yeah, so have you been in a situation in which the human intuition was really wrong? Because I can remember that there was talks about, no, this is exponential, right? And your feelings don't work here.
Right. At that point, so we partnered with a bunch of different groups, and so we had sort of average of models. That was just one of the groups doing it. At that point, so I think if we had seen that in like April of 2020, we might have freaked out. By then I forget when that was, it might have been like November or December. And so by then we had a little more of a feel for what exponential was meaning in that case, or at that point it was a little bit on its way down. Yeah,
all right, interesting, thanks.
But I would say that, yes, I can definitely imagine places where people have intuition and it's just not something you've seen before and they're flat out wrong. And hopefully you could point to the model and say, here's the assumption you're making that is incorrect in this case, and so you're going to see something different.
Yeah. Thanks, Jessie, for a wonderful talk and reminding us about the underground realities and the challenges. So my question is about the human in the loop, because many of the things that you mentioned is not perfect, right? Not automated algorithms. Did you have any experience in, like, say, taking feedback from humans and then trying to see whether the performance of, say, any of these algorithms could be made better?
So the one thing that comes to mind for improving the algorithms wasn't so much a human thing. It was the group that was doing the modeling didn't have the latest information on, they only had statewide information on hospital capacity. And once we were able to give them regional, more specific information, that was it, they were able to get more accurate. No, the human in the loop, the other thing that comes to mind is the pushback we got at the beginning when we were asking for race and ethnicity. And I think, hopefully I demonstrated that it truly was actionable. We were really understanding how those populations were being impacted. Whereas the providers on the ground, and no, like, I totally get what they were saying. They're like, look, every data piece you have me collect is time I'm not spending getting shots in arms. So, you know, it was a legitimate disagreement of like, what's worth the time here? So that was a human aspect, but it wasn't, not really human in the loop for accuracy there. Not a very satisfying answer, sorry.
No, that's helpful. Thanks.
Any other questions? Okay, one up there, and I think that's the last question before we head to lunch.
You're welcome for going a little short.
Thanks, a great talk. Can I just ask about the entity resolution? You mentioned briefly false positives and false negatives. How did you decide your tolerance, and what sort of mitigations did you take to whichever one you decide to accept more of?
Well, we said we were going to get people to lunch. I could talk for hours about all of that, but so we, unfortunately, and I didn't get, this is like a whole different talk I could give, but in North Carolina, we have 2 different IDs that we use as sort of universal, well, more than that, but 2 different ones for now. One is Master Patient Index that tends to be with clinical data, and one is the EER, Enterprise Entity Resolution, that tends to be more sort of analytics. And so for those, you have different levels of tolerance. For the clinical one, we're merging clinical data there. And if you accidentally merge Mike and Michael and then realize, oh crap, those are actually different people, you could be doing HIPAA violations, you could be giving out secured data. So for that one, we have a very stringent, like, we don't merge them unless we're really sure it's the same person. For the other ID, where it's more sort of post hoc analytics, we have a lower threshold there. It's a hard challenge because in order to know false positives and false negatives, you need golden truth. And sometimes I've been on projects where you can look at 2 and be like, I'm not sure if that's the same person or not. Like, are they twins? Was there a typo? Was it a divorce? Was it whatever? So you need to have the gold standard to measure it by. With the ones we were using, initially they didn't have good metrics for that. It was more like, here's what we've got, we're in a crisis, oops, sorry, we need to do it. There was something else I was gonna say there. False positives. So you need to decide, kind of based on your use case, what you're willing to tolerate for false positives and negatives. Oh, and then the other thing is to know that it's not gonna, that rate, the accuracy is not gonna be the same on different populations. So for example, we use referential data, so we're able to see if someone was in the DMV, the Department of Motor Vehicles. We have other records that help us to know. But for kids who don't have a lot of pre-existing records, that can be more challenging. There's also a big difference with Hispanic names, when you have kind of names will be joined, or they might be hyphenated, or that you might be missing the middle name because it looked like the last name, that sort of thing. So you can have different levels of accuracy there. I'm not sure if that answered your question, but it's a hard problem.
It is. Thanks very much.
Yeah.
Right. Well, I think it's time to thank our speaker again.